Grand. So, guys, my name's Ollie. I'm one of the ENT registrars at Royal Devon and Exeter. You guys are all across the southwest, aren't you? So you're from sort of Gloucester down to sort of Severn and Peninsula combined, aren't you?
Yeah.
All right. Yeah. Grand. So I've probably seen a few of you dotted across the counties of Devon and Cornwall over the last few years. James asked someone from ENT to talk about endocrine surgery, and one of our consultants delegated it to me purely because I'm recently post FRCS, so I'm in that wonderful post-exam glow of enjoying work and not having to revise for it anymore, but I do feel your pain with the slow trudge towards it. Regarding my presentation, because it was going to be pre-recorded, it's a little bit of death by PowerPoint, but because we're early in the day, hopefully you won't snooze through it. It would be fun if I had a few more quiz questions, but I don't. If you want the slides, or if you want to ask any questions about endocrine surgery at all, just drop me an email. I'm very happy to answer any. And just before I carry on, can you just see the single slide, or can you see presenter view as well? Just single slide? Someone nod?
Just single slide.
Just a slide.
Yeah.
Grand, perfect. You don't see my mad ramblings then. So regarding endocrine surgery, I had a look at your ISEP syllabus for general surgery and where thyroid and endocrine falls into that. And there are a few broad points that are made. I mean, certainly for your exam, you're expected to understand the genetically determined diseases related to breast, endocrine and gastrointestinal surgery. But more specifically for thyroids and parathyroids, you can be expected to be examined on your competency in the assessment and management of thyroid swellings and thyroid toxicosis, and also assessment and management of parathyroid disease. I'm certainly in no way qualified to talk to you about adrenal or pancreatic tumours. I'm very much a shoulders up surgeon, but they're coming up for you later in the day. So I'll go over thyroids and parathyroid surgery, hopefully in appropriate depth for an exam. Now, the exam itself, as you'll well know, splits into an MCQ and a Viva part. A lot of endocrine surgery can be asked on both of those. So the MCQ part can be very much fact-based and fact-focused, whereas the Vivas, where some slight more nuances of management can come into play. Now, I know certainly in Peninsula, so Devon and Cornwall, thyroid and parathyroid surgery is tending to move away from general surgery and more towards ENT. It's my understanding, certainly down here, there's not a huge opportunity for you guys to get involved with thyroid and parathyroid surgery. And the lion's share of this is done by ENT, and in some cases in the southwest, MaxFax. In Exeter, the majority of benign thyroid and parathyroid surgery is performed by Julie Dunn, who's a breast surgeon here, but since she's retired, that workload's entirely been taken on by ENT. Derriford and Truro, it's all ENT, but in Torbay, it's done by MaxFax. Again, looking at your syllabus and what's expected of you, to go into subspecialty thyroid and parathyroid surgery, you guys need to have done, I think, 50 thyroidectomies, 30 parathyroidectomies, which would be hugely challenging for you. And therefore, in terms of learning any more about it, is going to be in the realms of fellowships. If anyone does want to get involved with some thyroid and parathyroid surgery, I know we're all very busy, but if you're in the southwest and or Exeter specifically, or any other hospital, and you want to get involved in it, just drop me an email and I can put you in touch with the right people. They're always happy to have someone else along. But I should probably move on to some FRCS stuff. As with all things in the head and neck, it tends to come down to embryology and the pharyngeal or branchial arches. Now, I personally cannot conceive of how many times I had to run over the chart of what arch does what over and over again. And the best way to learn it is to find a way to learn it yourself rather than being told them. But with that being said, there are a few resources that I've put up here. You've probably known some of them. I think Teach Me Anatomy, although very simple, does cover the branchial arch as well. And there's a YouTube link there, which is probably the best for visually representing what happens with it. It's also only about 5 minutes long, but it does give you a good understanding of what it is. Here's the overall view that you can get from any textbook. The green line is the endoderm, the light blue is the mesoderm, and the dark blue is the ectoderm. The important parts relating to endocrine surgery are the third and fourth pouches. So that's in the endoderm, the green line. Clefts are on the outside, so your cleft sinuses and cleft cysts are all on the outside, and the pouches are on the inside. And also the foramen cecum, which sort of sits between the first and second arches in the middle is the embryological base of the tongue. This is the chart that I found most useful. It's slightly different setup to the ones that you'll mostly find in the textbooks. And you can see it's sort of probably been photocopied and put in onto Google Images so many times. But essentially, instead of showing you that both sides image, it just shows one side. And on the outside here, these are going to be the clefts, and on the inside are going to be the pouches. And specifically here, we're going to be looking at the third and the fourth pouch. So regarding thyroid embryology, it's good MCQ fodder for examiners. It includes clear facts, and they can irritatingly mess around with the wording to make an answer look correct when it isn't. Regarding the thyroid, it originates from the foramen cecum, as I've said, which is in the midline between the first and the second arches, the embryological base of the tongue. The development and migration begins in the third week, when the primitive pharynx proliferates to become the thyroid diverticulum. It then moves caudally in the midline, anterior to the hyoid bone, which is a derivative of the second arch, and anterior to the laryngeal cartilage framework, which is a derivative of the fourth arch. In the fifth to seventh week, it divides into the left and right lobes, and it should reach its final destination in the anteroinferior portion of the neck by the seventh week. The thyroglottal duct should obliterate by week 10, and failure of this at any point can lead to several congenital abnormalities, specifically pyramidal lobes, thyroglottal duct cysts, and sinuses. The embryology for the parathyroids is a little more complex. They originate from the third and fourth pharyngeal pouches, so the endoderm. Rather irritatingly, the third pouch becomes the inferior parathyroid, and the fourth pouch becomes the superior. That YouTube video link that I put up earlier shows this very well. The inferior parathyroids develop and descend alongside the thymus, whereas the superior parathyroids develop alongside the ultima branchial body. The ultima branchial body, if you're not sure if you remember from med school or at any point you've learnt it, is made up of the parafollicular C cells, which produce calcitonin. That's another question favoured by the FRCS MCQ masters, and that will come up later when we talk about medullary thyroid cancer as well. The main function of the parathyroid glands is obviously to do with calcium regulation. Parathyroid hormone is the functioning hormone which is released by chief cells in response to a low circulating calcium. The PTH itself acts on the bones, the kidneys, and the gut to increase osteoclastic activity in the bones. In the kidneys, it promotes calcium reabsorption and phosphate excretion, and it also contributes to the activation of vitamin D to encourage calcium absorption from the gut. And all these act on increasing circulating levels of calcium. There are also oxyphil cells in the parathyroid glands. They are much more poorly understood and felt that they may have a relation to secondary hyperparathyroidism, which we'll talk briefly about later. In terms of what to expect in terms of looking at your syllabus and things that you can be asked about, I'm not sure I can cover all potential thyroid pathology in a single talk, but I will run over probably some of the commonest things that you can be asked about. Benign thyroid pathology includes both functional and non-functional pathology. In terms of functional or non-functional, I'm not talking about the person who turns up with tinted glasses inside, teddy bears, and interesting coloured hair, but hormone functioning. So you can have benign hyper or hypothyroid conditions, but then you can have non-functioning pathology, which is mostly related to size and compressive symptoms. There are, of course, thyroid malignancies, which we'll go over later, and most of the vast majority of these are primary thyroid malignancies, but you can occasionally get metastases to the gland, but this is very, very rare. We'll start off talking about goiters. A goiter is an enlargement of the thyroid gland. It can be diffuse and generalized swelling, or it can be nodular, either as a result of a single nodule or multiple nodules. Historically, they've been linked with iodine deficiency, but they can also have genetic links. Most often, goiters are euthyroid, but nodules themselves can become hyperfunctioning or autonomous, which leads to hyperthyroidism. And you can also get goiters as a result of hypothyroid conditions. But in the vast majority of cases, they are euthyroid. In terms of management of a goiter, Usually, the only management is surgery, although there are some developing systems, so radiofrequency ablation and sort of funny ultrasound techniques to try and shrink down nodules. But in general, if it's large enough to be compressive, surgery is what patients need. Some people try and get their thyroids taken out for cosmetic reasons. That's not really funded in the NHS, but usually people can try and swing some compressive symptoms from that as well. Thyrotoxicosis, I won't insult your intelligence by going through the symptoms of thyrotoxicosis and hypothyroidism at any great length, but in general, it's the often described to patients as the accelerator pedal for the body. And if you're thyrotoxic, it feels like they can ask safe management questions. Thyroid storm is a life-threatening pathology and presents with hyperpyrexia, palpitations, shortness of breath, sweating, confusion, and disorientation. Treatment for this includes antipyretics, steroids, antithyroid medications, beta blockers, and high dependency or intensive care monitoring. Regarding Graves' disease, it is the commonest cause of hypothyroidism. It's an autoimmune thyroiditis with raised thyroid stimulating immunoglobulins. And now this is a measurement of thyroid receptor antibodies. It's essentially, this mimics the activity of TSH at the thyroid gland, tricking it into a constant production of T4 and T3. It does affect females more than males at a ratio of 5:1, and usually affects people in their in their mid-20s to the 50s. About 15% of cases have a positive family history. In terms of the workup, they will have raised thyroid stimulating immunoglobulins. They will have a high T3 and a T4 with an almost unrecordable TSH. Imaging studies usually are limited to ultrasound scanning, which will show a diffusely enlarged hypervascular gland. If there is a nodule within a thyrotoxic gland, it's usually encouraged not to sample it with fine needle aspiration cytology, as you're more likely to get a spurious result. Regarding management, first line certainly tends to be antithyroid medications, including carbimazole and propylthiouracil. An important point to note is that carbimazole can't be used in the first trimester of pregnancy, and that's certainly something that came up an awful lot in the ENT MCQ questions. They quite enjoy asking about thyroid medications in pregnancy. Surgery itself is curative, but tends to be reserved for patients who are intolerant of medications or young people who want to start families and don't want to be taking any medications. But afterwards, they will require lifelong thyroxine. However, that is a much safer drug to take than carbimazole, but there are risks of surgery associated, obviously. In poorly controlled thyrotoxic individuals who are planning surgery, they may require preoperative treatment to achieve a euthyroid state, which usually involves beta blockers and Lugol's iodine. Hashimoto's is a common cause of, or common pathological cause of hypothyroidism. It's another autoimmune condition which preferentially affects women more than men, with a ratio of 15:1 in this case. In this case, it's the antithyroid peroxidase antibodies that are raised. Patients are generally transiently hyperthyroid during the inflammatory phase of the condition, after which they are hypothyroid for the long haul. Management in the vast majority of cases is simple thyroid hormone replacement, unless there are suspicious nodules or compressive symptoms with a goiter. And it's worth noting that patients who have had Hashimoto's are at a greater risk of non-Hodgkin's lymphoma, which is another little tidbit that may come up in an MCQ. We'll now move on to malignant thyroid disease. And in general, it's a relatively common malignancy. In the vast majority of cases, we have very good outcomes. The risk factors for malignancy in the thyroid gland are a history of irradiation to the neck and a family history of thyroid malignancy. Nodules are common, and we'll go into that a little bit as well. The things that increase the likelihood of a nodule being malignant are the patient's age, if they're under 20 or over 70, if they have a history of familial adenomatous polyposis, if they have Cowden syndrome, Calvin syndrome came up loads in the ENT MCQs. I'm not 100% sure why, because we don't usually see it very often. But it tends to be patients presenting with benign hematomas, but they can be at a greater increased risk of malignancy as well. Young males are more likely to have a malignancy, or if they have a nodule, more likely to have a malignancy. And then there's obviously ones which show local invasion. So if patients are presenting with voice change with recurrent laryngeal nerve involvement, if the nodule itself is fixed to some surrounding structures, or if there's lymphadenopathy present at the time of diagnosis. We tend to break, or certainly at med school, you break down thyroid malignancies into papillary, follicular, medullary, and anaplastic. Now certainly in thyroid MDTs and in our workup, we tend to break that into three. So we have well-differentiated thyroid cancer, which includes your papillary and follicular variants, and then the medullary and the anaplastic. Well-differentiated thyroid cancers are common, and incidence is increasing, but deaths as a result of well-differentiated thyroid cancer are fairly static, which suggests that we're probably better at finding it rather than treating it. They tend to run fairly indolent paths, certainly papillary thyroid cancer anyway. And it's not uncommonly found at post-mortem, suggesting that people tend to die with it rather than of it. But in younger patients, it can be more aggressive. But in the most part, management is very successful with very high cure rates. Papillary thyroid cancer is the commonest. It makes up about 80% of thyroid malignancies. Again, histologically, it seems to like asking about histology in the MCQs. They have psammoma bodies and Orphanani nuclei. The 10-year survival is up to 98% and above. They tend to be very slow growing as well. Follicular variants are slightly more aggressive than papillary thyroid cancer, but still very, very treatable. They make up about 15% of thyroid malignancies. We have very good treatment options for well-differentiated thyroid cancer. Surgery is the mainstay of treatment. And this is either in the form of a hemi or a total thyroidectomy. There's currently a trial called the HOT trial, which is hemithyroidectomy or total thyroidectomy, which has been started to determine whether hemithyroidectomy is appropriate for small, well-differentiated thyroid cancers. If the histology on a diagnostic hemithyroidectomy is aggressive, so it shows local invasion, or it's of a certain size, or there are lymph nodes present, then these patients nearly always go on to have a total thyroidectomy. And following a total thyroidectomy, they can have radioiodine ablation. Now, this is used to mop up any microscopic disease based on the fact that the thyroid gland uses iodine to create thyroid hormone. So by radioactively labeling iodine, any leftover thyroid cells will mop up that iodine and be destroyed themselves. Now that works because these are well differentiated, so they do behave a little bit like thyroid tissue. That's not an option for the medullaries or the anaplastic treatments. Actually, I should have mentioned radioiodine ablation earlier for Graves, because it's a treatment for Graves as well. The problem with it is that the people who tend to need it tend to be people with young families, so they are technically radioactive for a short period of time, so need to stay away from their young children. Medullary thyroid cancer makes up a much smaller percentage, about 5%. It's generally quite challenging to manage, and unless a very small medullary thyroid cancer is picked up on a diagnostic lobectomy, they tend to have usually metastasized to the neck at the time of treatment. They can arise sporadically and spontaneously, or have familial or syndromic links. Going back to embryology, they arise from the neuroendocrine cells of the thyroid, which are the parafollicular cells, which come from the ultima branchial body, which again was the fourth pouch. These cells secrete calcitonin, which allows us to use this as a monitor for patients during their post-treatment surveillance. Currently, surgery is really the only realistic option. And these patients undergo total thyroidectomies and a level 6 neck dissection. So level 6 in the neck is anterior in the midline, and surgically when you're performing this, you're going between the two recurrent laryngeal nerves and taking that as your level 6 dissection. There's a high chance of occult nodal metastases, so it's not unusual to undergo an ipsilateral neck dissection at the time. Again, like I said, we monitor them with calcitonin and CEA post-operatively, and the best time to see whether your surgery has been successful is 6 months after surgery. We'll give you an information as to whether you've cleared all the disease. Due to the strong genetic and familial ties, prophylactic thyroidectomy is often recommended if patients have positive genetic screening, and the gene that we're concerned about is the RET proto-oncogene. As a sort of anecdote about this, we have a patient who had a suspicious nodule and underwent a diagnostic hemothyroidectomy, which was found to be medullary thyroid cancer. She carried the RET proto-oncogene, so subsequently both her children have had prophylactic thyroidectomies, and her brother had a prophylactic thyroidectomy. Interestingly, with her brother, he didn't have medullary thyroid cancer, but was found to have papillary thyroid cancer in his histology. So we treated him for that as well, but quite accidentally. Undifferentiated or anaplastic thyroid cancer is universally bad news. These cases present rapidly. Patients deteriorate rapidly. The key to appropriate management is early histological analysis so that you don't do inappropriately morbid surgery on these patients. Often, however, they come in with a life-threatening airway pathology and therefore end up with life-saving tracheostomies before you get the histology back. And though this gives patients time to get things in order, it does unfortunately prolong their suffering, and they tend to have quite miserable demises with cancer growing out through the tracheostomy, slowly blocking off the tracheostomy tube. Most patients are dead within weeks to months of diagnosis. And the only real management is supportive management. They're aggressively malignant with significant metastatic potential and invade local structures very easily. So they often invade into the trachea, into the esophagus. They can invade the carotid arteries. So they're generally quite miserable. They tend to occur in the elderly. And there's some theories to think that they could be well-differentiated thyroid cancers that have de-differentiated and just gone bonkers, but they are horrible pathologies to manage. I haven't mentioned thyroid lymphoma, but that is another thyroid malignancy, but you manage it very much in the same way that you manage normal lymphoma, so I'll leave that to the hematologists. Going back to thyroid nodules and the workup of these, they are very common. Autopsy studies have shown about 40 to 70% of people have a thyroid nodule, so they are most commonly incidental findings. It is, however, worth knowing that just because it's picked up incidentally, that does not decrease the chance that this is a malignant nodule. If it's shown to be on a PET scan, it carries about a 33% chance that that nodule is malignant. But in terms of your generalized workup for a thyroid nodule, they will need thyroid function tests. If it is a functioning nodule, so a toxic nodule, then it is much less likely to be malignant. They should undergo an ultrasound scan, and based on the level of risk of that, they go on to fine needle aspiration cytology. If you have a confirmed malignancy, you may want to consider a CT scan, and that's also based on your ultrasound scan findings. So if the ultrasound scan suggests some tracheal invasion or suggests a highly malignant condition, then you'll want to get a CT scan of the neck and chest to look for tracheal invasion and chest staging. If you have a large benign nodule that's diving down behind the sternum, a CT scan can give you an impression of compression and the level of retrosternal extension. Speaking of ultrasound grading, there are two commonly used systems. There's the U grading, which is used by the British Thyroid Association and the British Association of Endocrine and Thyroid Surgeons. So certainly in UK FRCS, I would recommend learning that. You may come across TIRADS, which is an American staging system. If you work in Derriford, they use TIRADS, whereas everywhere else I work, I've used U grading. The main difference I can tell is that TIRADS encourages much longer term ultrasound monitoring over diagnostic surgery, whereas U grading tends to favour more decisive decision making. And certainly the cynic in me suggests that the private healthcare systems in America do very well from many, many years of ultrasound surveillance. Essentially, U grading stratifies risk and plans further investigation. U1 or U2 results require no further investigations. However, anything of U3 or above warrants at least a fine needle aspiration to determine the malignant risk. So that takes us on to the cytology grading, which again beats, and the British Thyroid Association use the Bethesda scoring system, and that's based on fine needle aspiration cytology. Again, it's similarly graded from 1 to 5 based on malignancy risk, apart from Thy1, which means that the sample has been insufficient and needs repeating. If someone comes back with a Thy2 cytology, they don't really need any further management as the risk of malignancy is so low. However, if they've had a high U grading and then a Thy2, you may want to do a repeat ultrasound scan and cytology in about 6 months' time, to ensure nothing's changed. Thy3 again is indeterminate, and that can either be Thy3F, which suggests there's a follicular lesion of undetermined significance, and quoting papers, the malignancy risk of that is around 20 to 30%. Thy3A is an atypical lesion of undetermined significance, so you just don't have the follicular cells there, and the malignancy risk is lower with that. Now, your management of these can either be in the form of a diagnostic hemithyroidectomy, or if someone is significantly comorbid or patient preference, may lean towards ultrasound surveillance. Now, these risks are nationally quoted figures, but realistically, you should use your local services and your local degree of risk. So I rather painstakingly audited Derriford's cytology and ultimate malignancy risk. And actually, if you had a Thy3F in Derriford, your malignancy risk is only about 7%, which suggests that the cytopathologists are slightly conservative in their calling of Thy3F. Thy4 means it's suspicious for malignancy and the risk goes up to 50 to 75%. Again, these patients tend to be offered a diagnostic hemithyroidectomy in the first instance, as up to a quarter of patients will have unnecessary aggressive surgery. And also, we're doing more hemithyroidectomies for well-differentiated thyroid cancer. So people can always go back for a completion thyroidectomy if it's required, but a diagnostic hemi would be the first thing to do for them. Unless, of course, the patient prefers to have a one-stop surgery regardless of the pathology outcome. Thy5 is a malignancy in all but 3% of cases, and these often have a total thyroidectomy up front. All our cytology goes through the thyroid MDT, where it's very important to determine the investigations, the surveillance and ongoing management of patients with suspicious nodules, and also patients in their follow-up period. We usually have a joint benign and malignant thyroid MDT where I've worked. We go through the malignant cases first, then go through some of the more endocrine-related ones, which leads us nicely onto parathyroid disease. The vast majority of parathyroid problems relate to primary hyperparathyroidism, which in upwards of 90% of cases is due to single gland adenomatous disease. You can, however, have multiple glands, multiple adenomas in some cases, and certainly in the NEN syndromes, you can have 4-gland hyperplasia. Essentially, with primary hyperparathyroidism, you have an unregulated parathyroid hormone release. So despite having high calcium, an adenome will continue to produce parathyroid hormone. Secondary hyperparathyroidism occurs due to disease elsewhere, which is most commonly renal disease, as the body cannot produce enough vitamin D to increase GI absorption or excrete phosphate or reabsorb calcium. So they tend to have a high PTH, but they do tend to usually have a normal calcium. So these patients have an inappropriately high parathyroid hormone, but usually have a normal calcium. These patients are mostly managed medically with phosphate binders and alpha-calcidol. Tertiary hyperparathyroidism, which I haven't put here, occurs when the driver for secondary hyperparathyroidism has been removed. So if a renal patient's gone on to have a transplant. However, these individuals, once they've been corrected, the glands tend to become autonomous or have become autonomous by this point and just continue to produce parathyroid hormone without stimulation. In terms of the workup for these patients, it's usually picked up incidentally with screening for something else. The symptoms of hypercalcemia are very broad and very vague, and a lot of these patients end up having a whole plethora of blood tests before a high calcium is identified. But if someone comes up with a high calcium, they should have a parathyroid hormone level done, and also vitamin D levels, because patients can have low vitamin D levels, which will lead them to have a high parathyroid hormone level. They should have their renal function tested to look for evidence of end organ damage, and they should also have DEXA scans and renal ultrasounds to look for osteopenia or osteoporosis and the presence of renal stones. If patients are keen to undergo surgery, which would be curative in the vast majority of cases, they should undergo localization studies, which for parathyroids make up sestamibi scans, a nuclear medicine study, and then an ultrasound scan. And hopefully you get dual localization, which will help you with your surgical planning. If both these tests are negative, you can have a 4D CT, the fourth dimension being time, so it's a delayed washout scan. They can be used if nothing's on ultrasound scan or MIBI. Interestingly, though, choline PET scans, which you'll be aware of for prostate cancer, they're not licensed for hyperparathyroidism, but they are very good at picking up parathyroid adenomas. And we've certainly had a few patients who've paid for their choline PET scans privately to find a troublesome adenoma, which has then led to curative surgery. In terms of management, you can break it down into medical and surgical. It can be managed medically, but not very well. Cinacalcet, which is a calcium mimetic to increase the sensitivity of calcium sensing receptors on the chief cells of the parathyroids, is only usually used to buy time prior to surgery or if a patient is too comorbid to undergo a short general anaesthetic. In terms of what it does, well, it biochemically makes the patient look better, so normalizes the calcium and to a certain degree the parathyroid, but the patient's symptoms still stay at the same level. Vitamin D is also useful. It's very good perioperatively to prevent more aggressive dips in the post-surgery calcium levels. Surgery, however, if targeted, can be curative in over 90% of cases. Indications include a young age, a high calcium or a slightly raised calcium but symptomatic, if they have evidence of bone thinning on DEXA scanning, or if they have renal stones. Surgical approaches vary based on your preoperative imaging. If you have a dual localized adenoma, minimally invasive parathyroid surgery can take place. However, if no adenoma is identified, the operation can be a bit of an exploration and a hunting game, with a full neck exploration, full gland exploration, with or without on-table testing, which forms either frozen sectioning to send off to the lab to see if you've got parathyroid tissue, or on-table parathyroid hormone levels. Now, the half-life of parathyroid hormone is in the region of 15 to 20 minutes. So if you take a blood test at the start of the procedure, and then about 15 to 20 minutes after you take out what you think may be a gland, you can know whether your surgery has been successful or not. I think there's one centre in the country in London which has a finger prick parathyroid hormone level. We were thinking about getting that down here, but it was too expensive and didn't really change what we did anyway, so we left it alone. MEN syndromes, I'm getting towards the end of this, guys, now, don't worry. MEN syndromes are also a preferred topic for examiners. Certainly for my exam, I found that the nomenclature had changed to just MEN 1, 2 and 3 to save confusion, but essentially MEN2 can also be called MEN2A, and MEN3 can also be called MEN2B. For the sake of this, I'll say 2 and 3 because that's what I learned. 2 and 3 can be associated with the RET proto-oncogene and can be autosomal dominant. And as I've mentioned before, if the RET is positive, then a prophylactic thyroidectomy is recommended in children. MEN1, again, it's probably best for you guys to learn these from a book rather than be told them. I just remembered MEN1 as being all the P's, so the parathyroid hyperplasia, the pancreatic tumours and the pituitary tumours. But they can also have additional cutaneous tumours in lipomas and angiofibromas. MEN2, a bit nastier, with medullary thyroid cancer and pheochromocytoma and parathyroid hyperplasia. The presence of pheochromocytoma in the MEN2 syndrome does mean that if you have a patient with a new diagnosis of medullary thyroid cancer, they should have screening with plasma metanephrines and urinary catecholamines, as it's important to know about these preoperatively, just for more so for your anaesthetist. But again, these are managed surgically. MEN3. Now, the only thing I learnt about MEN3 was the fact that they have marfanoid habitus. It's the only thing that I could obviously see as a differentiating point between MEN2 and MEN3, and is a little tidbit of knowledge for an MCQ. So if you spot a question asked about a multiple endocrine neoplasia and they happen to mention the patient's been thin as a beanpole and very, very tall, then it's probably MEN3 is the answer. I'll do one last quick note about parathyroid carcinoma. Although it's quoted as about 1% of primary hyperparathyroidism, I have never seen a case of it. They present with very, very high serum calcium, very, very high parathyroid hormone levels. They can be over 100 when the normal range is about 1.5 to 7. And they often present with nodal mets as well. Management, again, is surgical in general, with a wide local excision and an ipsilateral hemithyroidectomy. And as you're there, you may as well do a selective neck dissection, as it doesn't really increase your morbidity very much. With positive margins or with nodal disease, you can have radiotherapy as well. but they can often metastasize to the liver, the lungs, and the bone. And death in these cases is usually a result of uncontrolled hypercalcemia. 5-year survival is not great, only 50%. So I'll finish there. I think I've covered everything that I could think would be useful for you guys to learn from an endocrine perspective. There is a lot of exam fodder in endocrine surgery due to the syndromes and due to the embryology. I think from a Viva point of view, they can ask you the nuances of management and the investigations and what you would do and when, which is difficult for you guys to learn if you don't really do much thyroid and parathyroid surgery in your current settings. But they are quite easy MDTs to turn up to. In fact, you could probably turn up to an MDT and no one would ask who you were because there's a lot of people in the room anyway. But again, if you do want to get involved with any parathyroid or endocrine surgery, let me know, and I can probably put you in touch with some of the guys in the hospitals that you work in if you wanted to come along and observe. Certainly if you're in Exeter and you want to come along and observe, they are nice operations, and you can watch me sweat and swear over a difficult thyroid if you want. So that's it really. I'm happy to have any questions if you have any. Hopefully it's all a bit weird when you do it by Teams because you can't hear whether anyone's asking anything, but hopefully it wasn't, the connection stayed the whole time.
That was brilliant.
Did it stay the whole time? Or was it?
Yeah, it seemed good. There's one question in the chat from Matt who's asking a bit about with Hashimoto's. Does that give you a sort of systemic risk for lymphoma, or is it just a risk factor for getting lymphoma within the thyroid?
So no, it's a systemic risk for non-Hodgkin's lymphoma.
Okay.
So I don't really know why. I never really read it for the exam, but it does. So I just used to learn it. It came up in one of the MCQs was a patient presents with widespread lymphadenopathy, and the only additional information was lifelong dose of levothyroxine, and the answer was Hashimoto's. So that was just a clue. So if you get a question of widespread lymphadenopathy and they've been on levothyroxine, the answer is probably Hashimoto's. As with most FRCS questions, it's all about pattern recognition and noticing the bits. Yeah. I've also got lots of MCQs. They are very ENT focused, but there will be lots of endocrine MCQs in there. So if people are leading up to the exam and want to do more and more boring practice, just email me. I'll see if I can hunt them down for you.
Brilliant. Great. Well, thanks, Ollie. Thanks for taking the time. I know you were.
No worries. Sorry, a bit of a death by PowerPoint.
No, it's great. I think if no one else has